Thank you, Richard, and thank you, Paul, for coordinating this forum. My talk's going to be about, I guess, one of the real challenges in health practice, which is how do we go from a really good idea, something that the evidence supports, to actually making it happen in the real world. So one of the things I'm going to be talking about is a research project which we've just been funded to do through New South Wales Health. This is actually the first formal injection of funding in New South Wales for naloxone programs, even though a number of us have been trying to do things now for a number of years. I want to acknowledge the team involved in this project, and you can see there's a lot of collaborators in this project. And they're a mixture of local health districts, so they're organisations that are involved in either drug and alcohol service delivery or run needle syringe programs. We have some NGOs such as MSIC involved, the Medically Supervised Injecting Centre. We have user groups, newer and carer groups, Family Drug Support, and we have a group of university or academic organisations, NDA, Burnet, Curtin, and AMREC, and many of the people in this room involved in this project. And also we've got government support through the Centre of Population Health. So this is actually bringing together a whole range of organisations, and I think it's one of the important things in understanding sort of translation research. It's how do you take it out of a research proposal and actually into services. So, background. In New South Wales, we first start dabbling formally with take-home naloxone back in 2011, when a small group of us at Kirkton Road Centre and at the Langton Centre, where I work, in Kirkton Road, where Ingrid Van Beek works. So we're services in Surrey Hills, Darlinghurst area, so inner city Sydney. We put together a proposal for funding to New South Wales Government for us to do a small little pilot feasibility of naloxone, take-home naloxone. We weren't successful, didn't get the money, but we decided to do it anyway. So we ran a little research project, and we did what everyone else was doing back then. And this is kind of like the history and the development of take-home naloxone programs pretty much all around the world. You get together and you kind of think, we'll do it, and what we'll do is we'll run a workshop, a 90-minute workshop, or a 2-hour workshop or a 3-hour workshop, and we're going to go and teach drug users everything they could possibly ever want to know, or don't want to know actually, about overdose and overdose prevention. And that's what we did, and we started running these workshops and trying to disseminate take-home naloxone within this model at the two services. And it was not dissimilar to, I guess, some of the other programs going on around Australia at the time. Over a 15-month period, we managed to give out 89 packs, which, considering the size of both the Langton Centre and Kirkton Road Centre, was pretty ordinary. Not great uptake. We did demonstrate high reversals, so there's a high rate of reversals in those individuals who we did follow up as part of the research project. We also demonstrated improvements in knowledge, attitudes amongst clients, and also that the staff generally were happy doing this. But we were concerned about the modest uptake, and so we went back to our clients and asked them, so what's the issue here? Why can't we even give this stuff to you? And there are a whole range of reasons, but one of the constant themes was this idea of a structured workshop which was run on a Tuesday at 10 o'clock on the third Wednesday of every month, unless it was a full moon, in which case it was, it just got really complicated. And people were saying, look, we want to be able to just part of either routine care or for it to be on demand. So, so we could pop in when we want it, or as part of our routine healthcare, rather than this idea of, naloxone workshop, get yourself to it. So coming out of that, then we identified that we needed to develop a briefer intervention. And in healthcare, we're pretty good with brief interventions. We do this stuff all the time. So it wasn't rocket science for us on how to put together a brief intervention. So a brief intervention is something that you deliver in about 10 to 20 minutes, and the idea is that this could be either integrated into routine healthcare. So the Langton Centre, I didn't mention, we're a drug and alcohol treatment service, so we've got big methadone buprenorphine programs, also outpatient withdrawal services. KRC is more a primary healthcare service located in the Cross, and their model is much more, whilst they do have a small methadone program, a lot of their work is really drop-in primary healthcare. So we're kind of thinking we've got 10 to 20 minutes with our clients to get this out. So how do you do it? So one of the things is, don't bother them with stuff they already know. This is standard stuff in brief intervention. So ask them what they already know and fill in the gaps. So reinforce existing knowledge and fill in the gaps of the things they don't know. So this was done initially with so ask them in a questionnaire. This is based on the kind of questionnaire we've been using in our evaluation research projects and widely used across Australia. Developed a client information sheet similar to what everyone else is using, and addressed those three key issues. What are the risks for an overdose? How to identify an overdose? And what to do if you see an overdose, how to respond to an overdose. So those are the three kind of key bits of information we were asking our clients about and then educating them with. And at the end of that 10 to 20 minute intervention, we gave them an overdose response kit. And this is a little kind of bag. We just went down to the $2 store and bought lots of pencil cases. They were about the right size and they were cheap. And then we stuffed them full of gloves and face masks and needles and so forth, and a sharps container. And importantly, when the time came, we were also stuffing it full with 2 0.4 milligram naloxones. So initially, in the early days, we were doing amps. Then we moved to mini jets. We still have got some mini jets that we were going to get rid of this week. And after this week, we're going back to the amps again because of the concerns around shelf life. Wrong way. And at the end of that, obviously ask clients any opportunities for questions. This is the client information sheet, and you can see there just the headings. Not particularly visually nice, but it fits on one page, and that was also one of the things that people kept saying to us. One page. We don't want something that kind of, is really thick and big and long and fine print. So again, our focus was to respond to what people were telling us. So, brief intervention, good, we started rolling that out. And then what we realised, to make anything work in a service, anyone who works in bureaucracies will understand, you need to get your policies and procedures right. You need a governance process. So we spent a lot of time getting our brief intervention approved by New South Wales Health structures. So it's gone through our pharmacy committee, it's gone through the forms committee. So you can actually get that form now. If you work in New South Wales Health, anyone who works in the hospitals will know, you can actually order this now on the SALMAT process. So this is official government business now. And that was really important, because one of the things that we were confronting all the time was, are we allowed to do this? And where's the policy and procedure that says I'm allowed to do this, that I'm protected? If you work in governments, you understand the mentality there. So, that became quite important, to make sure that this was part of a New South Wales Health, approved model. We had to train our workers, and all our work initially was done on prescription, and then once over-the-counter scheduling came in, that allowed our pharmacists and our services to also do this as over-the-counter. Since rolling it out in our service, a number of other places have picked up with it. So one of the things, so as I said, we've got it approved in our LHD through New South Wales Health. It's also, take-home naloxone is actually also written in the impending New South Wales opioid treatment program guidelines that should be coming out in the next couple of months. So in there it says to all the methadone doctors, thou can and thou should prescribe naloxone as a overdose prevention strategy. And we thought, yep, this is enough. Sit back and watch this just take off like wildfire. We were expecting, everyone across New South Wales would come, battering our door down to get our policies, procedures, and everyone would be rolling it out. And here we are about, 2 years later, and pretty much they're the services that have even sort of done any. So again, South East Sydney, which is where we started this off, Illawarra, Shoalhaven Local Health District. So if you're in Wollongong, you can get naloxone. And the history there is that Illawarra, Shoalhaven used to be part of us, so we in the previous incarnation. So it's kind of like the same area health service. St Vincent's, Rankin Court, have had a stop-start. They got trained and about to start soon. But really, other health services, Kirkton Road Centre, the MSIC have done a lot. and some peer-based services. So Newer have also been trying to run some workshops. So we estimate that in New South Wales, we've probably given out 600 to 700, maybe a little bit more, could be a little bit more, take-home naloxone packs. This does not include pharmacy, but we don't think a lot's happened in pharmacy. And just about all of that has been delivered in South East Sydney. So the big rollout, the big explosion that we were expecting would happen in New South Wales just has not eventuated. So that got us thinking, how do we do this? At the time, around this time, New South Wales Health put out a funding round called the Translational Research Grant Scheme. This is basically, so it's a competitive grants process, and we'll able to get funding to roll this out, to roll out a project which would look at seeding take-home naloxone across 5 LHD catchment areas. Now that's about half of New South Wales. So we've got 3 urban metropolitan LHD, so South East Sydney, Sydney LHD and Western Sydney. We've also got Hunter New England LHD and Murrumbidgee down south, and also we're pretty confident we're going to get North Coast, so up around the Byron Bay and Nimbin area might come on board as well. So we're looking at about half of the LHD catchment areas coming on board. And what we're really keen to look at doing is how can we develop this up, to roll this out as routine care in our drug and alcohol services and needle syringe services and in peer outreach. I'll come back to what that actually means in a moment. We also wanted to evaluate the effectiveness of the brief intervention, because all the previous work around Australia, when we all went and evaluated our program showing, yep, it works, that was all done largely on the longer versions. So we just want to be able to dot the I and cross the T, that even a brief intervention is adequate in improving knowledge. And we also want to get a sense of the costs involved in delivering take-home naloxone. There's a reason for that as well. So, what does it mean to deliver take-home naloxone to the target groups? And I just want to say that in the target group we are talking about are people who come from an injecting drug use background. We are really clear that sooner or later we're going to have to leave that population behind us, and then really do the mainstream focusing, which is the prescription opioid population. That's where most of our deaths are occurring. Most of our deaths are happening in 45-year-old men, not on OxyContin, not in 25-year-old injecting drug users. So in time, we are going to have to think about moving it beyond an injecting drug use population. But for this project, it's focusing on this group. So what we want to do is adapt it to the local service setting. So how might a needle syringe worker or a peer outreach worker deliver this? We want to consider accreditation models for an alternative workforce. Now, Schedule 4 means a doctor needs to write a prescription, or a nurse practitioner. Schedule 3 is really clear. A pharmacist must give out over the counter. No one else can. So what we're keen to look at is, could a needle syringe program be somehow credentialed so that they can actually give out the naloxone directly? And likewise with a peer outreach worker. So that's how we're working. We're working with our pharmaceutical services to look at, are there ways that we can circumvent that Schedule 3, Schedule 4 regulation so we can overcome that important barrier. We roll it out across those sites, aim for about half in drug and alcohol services, half in needle syringe outreach settings, and then we look to implement and evaluate the training. So that's the first objective. The second objective is to, in a subsample of 150 participants, enrol them and do what we did in most of those earlier projects in Australia, which is look at changes in overdose knowledge and skills, but we also want to follow them up 3 months later and importantly ask them about reversals and what health service utilisation they've had related to overdose. Now this is important because at the end of the day, our third objective is to look at the sustainability and feasibility of this being delivered within New South Wales health settings. Now what that means is New South Wales Health picks up the tab for the drugs. Now this becomes really, really important because GP model's fine, $6.20, you still got to get to a GP who may or may not bulk bill and who may or may not do it for you. And then you still got to go to a chemist. So there's all these steps in the way. And an over-the-counter is non-pharmaceutical services benefit. So there is no subsidy for over-the-counter. So people have to pay the commercial rates. So within a sort of a New South Wales health model, this is basically that you should be, well, we are looking at how can we make this rolled out in these kinds of services. So if you're in a government methadone program, needle syringe service, or as part of a peer outreach, that the naloxone hopefully will become freely available and in one step, so not having to go to doctors and needle syringe, different steps. So that's the economic analysis, and we want to make a business case that this is actually worthwhile New South Wales Health picking up the tab, and that's basically if we can demonstrate reductions in ambulances and in ED attendances, then naloxone's cheap in comparison to one ED presentation. It's an 18 to 24 month project. There's a governance is so ourselves, Kirkton Road, Newer, U Sydney and NDARC are the core group, and then we've got a project steering committee and separate working groups are looking at what does the intervention look like and also how do we do our research. The project coordinator is Lauren Mons, and that's her email, and I'm sure I've misspelt Sydney. You can tell I'm not a native. And you can contact her if you want more information. And there I might stop. Thank you.